Yeah, Dr. Helms, thank you for this very warm welcome. Dear colleagues, dear chairman, I'd like to share some data with you on current treatment strategies in patients with newly diagnosed heart failure. We did some studies in Hannover. I want to mention these as well, but I want to start with this. These are my conflicts. I want to start with this slide, and this shows basically, or this illustrates the correlation between LV function and the risk of ventricular tachyarrhythmias. So when we look at the first graph here, this is the LV function over time, and what we see is patient has normal LV function, and then it happens that it deteriorates. So he gets in acute heart failure, LV function is low. And correspondingly, we know, and this is what Dr. Helms also already mentioned, that the risk of VT-VF increases when LV function decreases. So, and then we have two scenarios. There's scenario A. This is a patient. Who recovers from LV deterioration, so by intervention, by heart failure, medication treatment, whatever. And correspondingly, his risk for ventricular tachyarrhythmias lowers again. So he may not need an ICD in the chronic phase. But there are also patients who do not recover from low ejection fraction. And in these patients, the risk of VT-VF stays high. So these are candidates or potential candidates for an implantable cardioverter defibrillator. If you look at the IRIDES trial, IRIDES trial was a trial implanting ICDs early after myocardial infarction. And we all know this trial was not positive for improving the prognosis with respect to all-cause mortality. But if we look at the risk for sudden cardiac death, we see that the ICD groups has lower risk for sudden cardiac death than the control group. If we look in detail on this graph, we see that the benefit from ICD seems to be very prominent in the early phase of heart failure or post-MI. So we see here these curves diverge in the first 6 to 9 months. And if we do a little trick, I would say, and we start the follow-up at 9 months or so and put them both to 0, then we see in the chronic phase there is no difference between ICD group and control group. So the risk of VT-VF seems to be very high in the beginning after MI. And this was also shown in a registry using the WCD from the US. And this was a retrospective analysis with 1,400 patients. They were matched, 700 had an ICD, and 700 served as a control group without an WCD. Sorry. And what we see here in the long-term prognosis of these patients, these curves diverge in the early phase. So the WCD patients do better with respect to survival than the patients who did not receive the WCD. And in the chronic phase, we see these curves are more or less parallel. So I think from this data, we can conclude that it's important to look after sudden death in the early phase after heart failure diagnosis. So this is all you know. These are the guidelines to implant an ICD in patients with ischemic and non-ischemic cardiomyopathy. So what we have is we diagnose the patient with heart failure, and then we have after 6 weeks, according to the guidelines, the possibility to implant an ICD in the ischemic patient or in the non-ischemic patient after 3 months. So what to do before? And this is the window where the WCD takes place or has an indication. And this is also covered by the ESC guidelines, the VT-VF guidelines, as well as the heart failure guidelines. We see all over patients at temporary risk for sudden death or who have no ICD indication by now, or ICD implantation is actually not possible. These patients have an indication to be in inflammatory heart disease 2A, level of evidence C. This is all through the guidelines. So if we go back and look again to the recommendations, we see here that it's important to treat this patient more than 3 months, optimal medically therapy is demanded. So the problem is, after 6 weeks, we cannot reach this stable condition, and even not after 3 months, we have not this stable condition of optimal medical therapy. So the question is whether we have to prolong treatment, heart failure treatment, to maybe 6 months after diagnosis. And this was even more stressed by a recent published paper on, in the European Heart Journal. And this stresses the importance of optimization of heart failure therapy. And included were 2,100 patients with reduced ejection fraction in 11 European countries. And these patients were followed up over 2 years. And these patients were included if they were had optimally uptitrated medication. And the endpoint of the study was to look at the mortality of this patient with respect to the degree of uptitration. So the investigators looked how much % of the recommended target dose did this patient reach with respect to ACE inhibitors or ARB and beta blockers. And what they found is very interesting, because if you look here, this is the left graph is for ACE inhibitors and ARB. So the blue and the black line shows you the patients who had 100% or 50 to 100% of the recommended dose of ACE inhibitors. And their prognosis was much better than patients who had no ACE inhibitor or a very, very low percentage of the recommended target dose. And the same you see here for the beta blockers. Patients not receiving beta blockers or even at low dose beta blockers had a worse prognosis than patients having more than 50% of the target dose. So this stresses again the importance of uptitration of the heart failure therapy. I want to share now some data on what we have done in Hannover over the last 5 years. So we have prescribed the WCD in almost 400 patients in the last 5 years. And here you see the indications we have. And I want to stress that more than 75% of our indication was newly diagnosed heart failure. So patients we are talking about now. And here, just to show you, the whole population had an age of 57, mean age of 57 years, almost 70% males, low ejection fraction 24%. Wear time was almost 3 months in mean. Compliance was about 20 hours per day, and we had 4% WCD shocks. Out of this large group of patients, we studied a subgroup of 156 patients, and what we did is we wanted to show if we prolong the WCD varying, not only 6 weeks, not only 3 months, but maybe 6 or 9 months. And we included these 156 patients, mean age 54 years, almost males, low ejection fraction, and here you see the etiology of the included patients. This is the workflow or the study flow we invented. So we saw a patient with newly diagnosed heart failure. He received the WCD, and we started heart failure therapy uptitration. And after 3 months, we saw him again, did measure the LV function. And if the patient recovered to more than 35%, he left the window for primary prophylactic ICD implantation. So no ICD indication, patient was clinically followed. If the patient did still have an LV function of less than 35%, we looked at what was the LV function, 30 to 35. Did we see an increase, a delta LV function of more than 5% within the last 3 months? Or did we see an insufficient optimization of heart failure therapy? If one of these 3 points was positive, then we recommended to prolong this WCD wearing period, and we saw the patient again after 3 months. If all these 3 points were not met, then we saw an ICD implantation, implanted an ICD, and followed the patient clinically. So what were the results of this trial? So here we have the 156 patients with newly diagnosed heart failures. We excluded patients receiving an CRT because this is modulating, obviously, the LV function. And then we stay with these 2 groups. First, we saw early improvers. These are patients who improved LV function within the first 3 months to more than 35%, and these were 46% of the patient group. But even larger, the group of early non-improvers. These were patients who did not show an LV function over 35% within the first 3 months of follow-up. And out of this group, following the flowchart I have presented before, we found during long-term follow-up another almost 20% of patients improving LV function to more than 35%. So these patients, these 20% of our population were not candidates for primary preventive ICD implantation anymore. So we ended up with 56% improvers to more than 35%. Here again, you see at diagnosis, all the patients had a low ejection fraction of less than 35%. After 3 months, we had about 45% with the ejection fraction of more than 35%. And here you see the increase we saw during long-term follow-up. I want to stress the medication in these patients. And what we see here, 96% had beta blockers at discharge from hospital. 97% of the patient had ACE inhibitors or ARBs, and 90% had already MRAs. So they are very good treated at discharge. But also, I want to stress that we could increase during follow-up, and even in the first 3 months, the percent of the target dose in these patients from 47% to 63%. For beta blockers, from 45% to 65% in ACE inhibitors, and from 49% to 55% in the mineralocorticoid receptor antagonists. So this is very important to improve LV function during follow-up. Now you may ask, okay, why do we need the vest in this period? Because we can put them on medication and let them go and see them and do echoes and so on. So what we found is we had considerable numbers of WCD intervention due to VT and VF in the early phase, within the first 3 months, but also in the prolonging period. So this is 4 months, this is after 5 months. So during this period, we had a considerable numbers of VT, VF in the patients who were actually shocked by the WCD. And our data correspond to the VERI2 registry, a big registry performed in the US. And also the colleagues around Dr. Kutifa found that there was an improvement of LV function after WCD varying to around 40% in 40% of the patients. So these patients were not longer candidates for primary preventive ICD implantation. Another point, or another thing I want to stress is the risk of VT-VF in newly diagnosed non-ischemic cardiomyopathy patients. And this is a sub-study from our prolonged registry. So within these 156 patients, we had 117 patients with non-ischemic cardiomyopathy. And this population is very interesting by now after publication of the Danish trial, looking at the chronic phase in these patients, but we wanted to look at the acute phase in these patients. So we had 117 patients studied, and these patients were very well treated with heart failure medication. You see over 90% for beta blocker, ACE inhibitors, and MRAs. And what we found in these patients, if we only look at the risk for VT-VF in these patients, We had WCU wear time of 101 days in mean, and we found 12 ventricular arrhythmias in 10 patients. And a large proportion was in patients with dilated cardiomyopathy, and a third of these VT-VF occurred in patients with peripartum cardiomyopathy. So we had a lot of VT-VF, I would say, strikingly a lot of VT-VF in this early phase in the NICM patients. And this is here you see when this happened. So this happened in the early phase, but also in the later phase. So up to day 160, we had the last shock in these patients. And if we interpolate our results of the acute, the early phase in NICM patients, we have in our population 39 per 100 person years VT-VF. If we look at the Danish trial, and only the ICD group, not the CRT group, only the ICD group, in the chronic phase, there were 6 events per 100 patient years. So according to our data, if we compare these two event rates, we have a 6-fold higher event rate in the early phase of non-ischemic cardiomyopathy. So what we have found in our retrospective analysis, we are now studying in prospectively. In the HF-OPT trial, this is a multi-center trial. It started just now in Germany at our center 6 weeks ago. It is run in the US and Europe. This is prospective, non-randomized. We think we have to include 800 patients, and the primary endpoint is the LV function recovery later than 3 months after diagnosis. So in this prolonged varying period of the WCD. And there are a lot of secondary endpoints. We look at VT-VF, SVT, bradycardia, compliance, and costs. But the primary endpoint in this trial is recovery from LV function deterioration to more than 35% after 3 months of therapy. This is the flow chart. You may recognize it. It is quite similar to the one we have already published. So let me conclude, ladies and gentlemen and chairman. The WCD provides protected time for up-titration of heart failure medication and reverse remodeling. I think it is important to implement the WCD in heart failure workflows, heart failure therapy workflows. I think it's very important to take time until the decision of a primary preventive ICD implantation is taken. And of course, we need still more evidence, especially also on the long-term prognostic benefit of WCD usage in the early phase of heart failure. Thank you very much for your attention.
Dr. Veltmann, great presentation. Thank you for the data. I'm very impressed. One question from my side. LVEF is an important factor, no doubt about that. What do you think about other predictors in background to that, what you have presented?
So in our study, we wanted to be close to clinical routine, because by now we decide implanting an ICD or not. The only parameter we have is LV function. So we wanted to stay very close to the clinical life we have actually. I think it becomes very important to look after MRI criteria. I think there are very, very good data on patients with non-ischemic cardiomyopathy on the degree because the degree of late gadolinium enhancement correlates very well with the occurrence of VT-VF. So I think this is a promising risk stratifiers in patients, not only below 35%, but also above 35%. But these are studies which have to be done. Retrospective analysis and meta-analysis data are very promising, but I think this has to be studied prospectively.
Just a question about your study. How will you assess the left ventricular ejection fraction, by echocardiography?
Yeah, and this was only by echo. Yeah.
Do you plan to use a core lab for that? Or?
Yes, in the HF-OPT trial, we have a core lab which collects the baseline echo, the echo after 3 months, and then later on echoes.
Thank you. I must say that I am a little bit jealous because I am the only non-German speaker, and you are very lucky because in France, unfortunately, we don't have the indication today for non-ischemic cardiomyopathy during the improvement of medical therapy. But I think it's very, very important indication for that, and we are working to get the indication now in France because sometimes we saw some patients, we have a dramatic improvement in LVEF, and so they will not have an ICD indication. And I want to remind you that it's easy to implant an ICD. It's 30 to 40 minutes. For a VVI, it's very easy. But the problem is during the follow-up, and especially the risk of infection. And I think that I fully support your study to see if sometimes we cannot avoid implantation of ICD in patients.